literature, not the least of which are in these two books I showed you. This is the series of drawings that were performed by Rashid Idris, who I've known for 20 years. When I ask him to draw these for me, we get on the telephone, and I literally tell him what we need on the telephone, and more often than not, the drawings are perfect when I get to see them the first time. This is showing the harvesting of the pericardium. This is the right atrial view, and you can notice here is the atrial septal defect is here, and these are the pulmonary veins in the left atrium. I show this to you because, first of all, that's the anatomy, and second of all, this is the left-sided maze procedure that can be done through the atrial septal defect and can be stretched here, as you can see. And the idea is to isolate the confluence of pulmonary veins. This is one view of it, and then the other view showing the complete isolation of the pulmonary veins, as noted by this cryoablation probe. Then, to finish the lesion set, one performs a lesion from the confluence of pulmonary veins here into the left atrial appendage, and then the last one is from the confluence of pulmonary veins into the third scallop, the P3 scallop of the mitral valve annulus. I stop here for a moment to remark about the drawings that one can see here. They're absolutely perfect. And I hope that we're appreciating the idea that now we can see the anatomy not only figuratively, but also anatomically the way one sees it in the operating room. This is what I see. The right-sided lesion, now we've already done the left side. Notice the way the artist put the remnants of that ridge that was made from the left atrial isolation, the pulmonary vein. Did you see it here? He left it in there. I didn't ask him to do this. He's so talented that he can do this by himself. And then the other lesion is from the tricuspid annulus, touching the coronary sinus and into the inferior vena cava posteriorly, and then the other one is anteriorly here to the os of the inferior vena cava. This shows the hole being closed with a piece of pericardium, and the de-airing, you can notice there. And this shows where the fenestration is if the patient has pulmonary hypertension. You can see here it's usually in the middle. I put a little clip there so that when the patient gets better and the pulmonary hypertension abates, then this can be closed by catheterization techniques. And of course, it's real important to get rid of the air. And this, you can see the hand here showing you just how big the heart is. And one can squeeze the heart here. There are a lot of ways of doing this, but this is how I do it. We get rid of the air in the left ventricle. This is showing another patient with an atrial septal defect, a different kind. This is a sinus venosus atrial septal defect with partial anomalous pulmonary venous return. I show this to see the phrenic nerve here that one has to be careful to avoid. This is what it looks like. This is where the atrial septal defect was in the past lesions. Now the atrial septal defect is here. You can see that these pulmonary veins are entering in the right atrium. The idea is to tunnel these into the left atrium. One can do this with a patch. You can see here. This is the way it's going. The patch is going in here, pericardium, and then the tunnel can be performed this way with this patch. And this shows the ghost views that I call them from the pulmonary veins going into the right atrium, but now they can't mix in the right atrium because there's a tunnel being constructed, and that goes into the left atrium. Sometimes patients have pulmonary veins that are going high into the superior vena cava. So this is a real conundrum to the surgeon. And there's a lot of ways, a couple of ways of doing this. I choose to do it in this manner. One makes an incision here in the right atrium, and then makes the vena cava transection here. So that means this blue tube of the superior vena cava is going to be transferred or transferred into a red tube. So the blue tube was the superior vena cava coming down into this area. Now, since that's transected and put in a patches place here, these veins are red veins now, they're going to go into the superior vena cava, and now it's up to this patch to make the tunnel from this into the left atrium. Now, what are we going to do about and here's the ghost fuse showing this, this configuration. Now, what do we do with the superior vena cava? Well, the superior vena cava has to be sutured into the atrial appendage, the right atrial appendage, and you can see it, how that's performed here. And this is what it looks like. This is the superior vena cava now, not into the os of the continuation of the superior vena cava, because this now is a red tube, and so this blue tube goes into the atrial appendage, and this works out quite nicely. We're not finished. There are other forms of partial anomalous pulmonary venous return, and this one is the left-sided veins. Mostly it's the left upper and left middle, draining into what's called a vertical vein, and that goes into the brachiocephalic vein, and then it's red blood mixing with blue blood, and some patients can get a right heart failure for this with a large left to right shunt. So this is the what one sees after the aorta is cross-clamped and cardioplegia is given here. And the idea is to disconnect this vertical vein, oversew it, and then somehow to get this red blood back to the red side of the heart. And one can see here an incision that can be made. This is a left atrial appendage, not the right atrial appendage. Now the idea is to suture this left atrial appendage to that anomalous vein. Notice that the incision on the left atrial appendage is made such as a fish mouth. Those of you who are fishermen can know what I'm talking about. This is incised so that this can anastomose to that. And then these trabeculations in the left atrial appendage have to be cut out to make sure that there's no obstruction. This is what it looks like. Lifts the left atrial appendage to the vertical vein, and that's what it looks like when it's finished. Still not finished. This is a scimitar syndrome. Now, what is a scimitar syndrome? It's an anomalous pulmonary venous return of this pulmonary vein, which looks like a scimitar or a sword. It's a Turkish sword, and that's why it's called a scimitar syndrome. It drains into the inferior vena cava. These patients also have other anomalies that have to be dealt with. The idea is to disconnect this pulmonary vein from its attachment into the inferior vena cava, and then an enterocide into the left atrium. This is what it looks like here, and then when it's finished, one can see that red blood gets back to red atrium. So ASD and pulmonary venous return, partial anomalous pulmonary venous return, are highly variable. Maze procedures in patients who are over 40 are indicated. The question of whether a prophylactic maze should be done, there are no prospective data on this, but it seems reasonable. And of course, there should be a therapeutic maze for anyone who has atrial fibrillation or atrial reentry tachycardia. Patients with pulmonary hypertension and ASD, we have very good potent vasodilators for pulmonary hypertension, and these can be managed even before the operation is performed for a few months, and then afterwards a fenestration is indicated, which is sort of serves as a pop-off valve, if you will, and that can be closed at a later time. If these tenets are followed, these results are excellent. Now, going to Ebstein's anomaly of the tricuspid valve. These patients present with tricuspid regurgitation. They have atrial septal defects, and they have atrial arrhythmias, which can be atrial fibrillation, atrial reentry tachycardia, or accessory connections. The indications recently have been liberalized due to improved results, and this absolutely brilliant Brazilian surgeon named De Silva introduced the cone operation. He's not only brilliant, he's a nice man. I spent 2 hours with him in Brazil teaching me how to do this operation. He is one of the nicest men you can find. And he's generous with his time, and he wants everyone to know this. And in fact, this has now been the procedure of choice around the world owing to his excellent papers and willingness to teach people. So the incision in the right atrium is like this. Now here's a tricuspid valve. It's a tricuspid valve from Mars. It's not anything that one can readily say as a tricuspid valve. This is the anterior leaflet here, and this is an atrialized portion into the right ventricle. And notice there that there's a large moiety here without any other tricuspid leaflet to abut to it, and this is wide open tricuspid regurgitation. He was a brave, intrepid surgeon, because he was able to take down this large anterior leaflet here, as noted, and cut all these trabeculations behind it to free up this tricuspid anterior leaflet, such as it is see right here. And by freeing this up, he's able to turn it around clockwise and make a cone, obviously called the cone operation. And he sutures this together here. And the idea is to take this leaflet, instead of having it attached here, to attach it over here to the true annulus. And so he does this by making the cone first, as you can see here, and then making the ventricle here a little smaller so that this will fit into a new annulus. In order to make that work, one has to make the annulus smaller, which can be done in 3 or 4 tacking sutures here. Remember, right over here, or excuse me, right over here is the right coronary artery. This is a major complication if one has a misadventure. All these things have to be kept in mind. Then once this is performed, this can be reattached to the true annulus. Notice here, this is the cone. It's looking more like a tricuspid valve. This is a ring being placed. Notice that the sutures are not only bolstering the ring on the annulus, but also taking some of the tricuspid annulus, the tricuspid valve, so that this doesn't disrupt. And this is what it looks like in the end. Absolutely terrific operation. It has revolutionized the repair for Ebstein's anomaly of the tricuspid valve. So now we go forward to coarctation of the aorta. One thinks of coarctation of the aorta in children, and which it usually should be. However, sometimes patients do miss, the diagnosis is missed, and they present for the first time as native coarctation, or in fact, many times as recurrent coarctation. They have systemic hypertension, large collateral vessels, and it's often discovered serendipitously doing a physical examination, mainly because the collaterals around the aorta have been well developed, and the problems with claudication don't come up. So there's been a change in therapeutic interventions, I would say, in the last 10 years or so, 8 years. The covered stents now have been developed and have been used successfully to do this, to treat patients with coarctation without surgery. However, there's still a role for surgery owing to long coarcted segments, and I'm going to show you that in a few moments. This is to give an idea about what coarctation is in the modern day in a child. One performs what's called a extended end-to-end anastomosis. The clamp is placed here. This patient is not on cardiopulmonary bypass. The lines of incision are noted here, and once those things are done and this coarcted segment and the patent ductus arteriosus are removed, it's a matter of putting these two incised, I call them bananas, to do an extended end-to-end anastomosis. That's what it looks like to start with, and that's what it looks like most of the time when we finish. I say most of the time because there is an incidence of recurrent coarctation, which generally is treated with balloon dilatation. Now, getting back to the idea of using covered stents, this you can see here is almost interrupted aortic arch. It really isn't. There is some communication here, and that can be done in stages. This is the first stage, and then after a while, one can come back with cardiac catheterization and increase the size and treat this patient with coarctation in a credible manner. This is surgery if it's performed. This shows from a left thoracotomy where the coarctation is and the recurrent laryngeal nerve. And one does here, because the patient is older and the arteries are less compliant, one has to consider doing a interposition graft in these patients. The good thing about this is that that no future catheterizations would be necessary, and the pulsatile flow is immediate and long-standing. Sometimes the coarcted segment here is associated with a very narrow transverse arch, as you can see here, and it goes into the area underneath the anomaly artery. This would be very difficult to do with just a left thoracotomy, which is this, and without using cardiopulmonary bypass. So one can see here using partial bypass, that is to say, a catheter in the left atrium here, one in the descending aorta. One can do partial cardiopulmonary bypass. If the dissection requires too close into the ascending aorta, and there's no other way to do this except by drainage of the inferior vena cava, the atrial appendage, and perfusion into the aorta, and a small short period of circulatory rest, will be able to fix this transverse arch stenosis with an interposition graft. So one can also perform this from the front, and this shows a median sternotomy approach with cardioplegia. And then here are the dotted line. This is the dotted line which indicates where the incision is performed. The incision is performed this way, and then the patch can be placed to fix this coarctation. Sometimes patients have had multiple operations in the area of the coarctation, and there's no credible way of doing this except with an extra anatomic repair. And that'll become obvious to you when we look at this. This is a descending aorta here, and this is a great big graft that is anastomosed end to side into the descending aorta. Once that's performed, then the pericardial flap is placed back into its area so that there's no chance of having a fistula into the esophagus here. Notice that this is clamped here. There is still flow in the descending aorta. Then it's a relatively simple matter to extend this patch, or this graft rather, into the ascending aorta and perform an end-to-side anastomosis into the ascending aorta. This is what it looks like. This is a nice alternative to going back here, because in redo operations, the recurrent laryngeal nerve is threatened, so is the phrenic nerve. The trouble with this is that these grafts can erode. They can erode into the superior vena cava, into the lung, and also into the esophagus. While it looks great here, there are complications associated therewith. And then we have patients who have left ventricular outflow tract obstruction. Sometimes it's a subaortic membrane. Other times it's idiopathic hypertrophic subaortic stenosis, otherwise known as hypertrophic cardiomyopathy. These patients can have concentric hypertrophy, or they can have septal hypertrophy. The risks include of not doing operations include sudden death and ventricular arrhythmias. This is an artist's view of a transaortic incision, and you can see here. And then you don't see a cardioplegia here because most of the time it's giving retrograde. And by retracting the valves of the aorta, one can see a buildup of muscle, which in this case is the interventricular septum. The conduction system is right here. That needs to be avoided at all costs. And then one can now start the incision with a scalpel. And then once the scalpel is continued, then one can also use a scissor if one wants. This is what it looks like right below the aortic valve. However, there's more to do. And this is a side view of the ventricle and the interventricular septum. In this case, this is septal hypertrophy, and then more incision and more excision of the septum requires to be done. And one can see here how this has been already incised, and there's more to do here. Notice that this is kind of an hourglass kind of incision because of the conduction system, which is right here. One can go past it and then make a larger incision since we're past the conduction system. This is what it looks like as it's being removed. And then one can see here how it's performed from the side view. It's a very difficult exposure to show people. I thought Rashid Idris did a beautiful job of this. Sometimes And one can see it also from this view, cut away, that the incision is made, and then notice how that the larger portion of it is in the ventricle away from the conduction system. Sometimes the muscle buildup is so much that a ventricular incision will be necessary, such as it is here in the left ventricle. One can make a fish mouth incision there. And here is the septal bulge. There's also concentric hypertrophy as well. But there's also some hypertrophy that is very difficult to manage from a transaortic area, and that is the papillary muscles. They have abrasions on it from the turbulence of the flow through the ventricle, and these can be removed by knife incision, and also can be trimmed here as noticed. And then once this is performed, then the ventricle can be closed. Surprisingly enough, these operations are very well tolerated, despite the fact that a left ventricular incision is required for optimal resection. The results from the Mayo Clinic and the Cleveland Clinic are excellent. The reported short-term results are very gratifying, and the long-term results, at least so far, are sustained. The incidence of heart block is low, and the symptoms are much improved. The ascending thoracic aneurysms are very interesting for an adult congenital heart surgeon. They involve patients who have Marfan syndrome and Louis-Dietz syndrome. They present by enlarging aneurysms and sometimes with dissections. The mortality is high if not operated with the appropriate operation. And the operative techniques include a Bentall operation, which is an ascending aorta and aortic valve replacement. So that means these grafts have a valve inside it that can be implanted. The aortic valve, if it's insufficient, is usually removed, and the coronary arteries are reimplanted. This is not the best way of dealing with this. The best way is if the valve is appropriately competent, then one can do a David procedure, which is a valve-sparing aortic arch replacement, or a Florida sleeve operation, which again is also a valve-sparing aortic arch replacement. Because Tom Martin was here, and because he was so generous with his teaching abilities, as we all know, we miss him very much, clearly. He taught me how to do this operation, for which I'm grateful. This is a ascending aortic aneurysm, as you can see here. And also one can see behind here there'll be coronary arteries, and this is the cannulation technique, which involves the retrograde cardioplegia. And so once the ascending aortic aneurysm is resected, as you can see here, the coronaries are dissected, and this shows the retraction of the proximal aorta. This also shows low setting Bovie dissection. Notice the smoke here. He thinks of everything. I'm just amazed. When I show these pictures to people, their jaw drops. It really is. And as if you can figure out so far, part of these grand rounds is not so much me talking, but him showing him these pictures, which are unbelievably excellent, shall we say. Anyway, this is the right coronary artery, left coronary artery. And then this is human proportionality. He basically tells you how big this graft is by showing the hand, right? And the hand, we know how big it is, so now we know how big the graft is as well. And so these are the incisions that are made in this graft. And the graft is shown here. How many of you have known the great cathedral in Istanbul called Hagia Sophia? Yeah, maybe? Anyway, it's an old cathedral, and the dome was put together by little windows all the way around the base of the dome. And when the sun shines through, these little fenestrations disappear, and it's as if you're looking up. It's as if the dome is hovering without anything else over it, like a halo, that kind of thing. I like to think of this as a hovering dome, because what he has done here, what the artist has done, he showed that where these sutures are being placed exactly where they should be placed. And he shows this in a dome configuration to tell you where to put them. Now, this graph you can't do this to a graph in the operating room, but as you see it, you can visualize it and know how to do the operation. And then once the graft is placed around the aorta, as you can see here, it's implanted, and then using a felt, the top part of the aorta is attached to the top part of the graft. This is what it looks like being tied. And then another graft is used to recreate the ascending aorta to the distal ascending aorta, and then to what it looks like when it's finished. Noticed here in the ghost views of the right coronary artery, right behind the fold of the right ventricle. Now, when these grafts, when the dissection and the aneurysm goes into the transverse arch, it presents a significant, difficult part of the operation. This is showing the Florida sleeve finished, but then we have these little problems here. All the aneurysmal tissue has been resected, and now we have to do something about this. So the first thing to do is to try to minimize the amount of circulatory arrest, and one does that by putting in a graft to the confluence here of the innominate artery and the left carotid. Notice that there is a bypass circuit in this graft, and this has been oversewn. So once this is performed, this anastomosis, one can now go on partial bypass and perfuse the head, right, or the head vessels. So now this circulatory arrest is over, which takes maybe 8 minutes to do this anastomosis, which is very good for the patient. So we go the extra mile to do this, obviously for the good of the patient. Once that's done, then we have another problem here. We have to get the flow to the descending aorta, right? So once another graft is placed, then another catheter can be placed into the descending aorta, and now we have flow not only to the head vessels, but also to the rest of the body, with the exception of the heart, which will come later. So this takes a very short period of time, and the amount of circulatory arrest time is very short, and responsible for the excellent outcomes that are achieved with this kind of operation. Notice that this part of the operation now is being performed. Now you got to get this brachiocephalic tube into the ascending aorta, which is shown here, and then this is the end result of this. One of the wonderful things about this atlas is that it shows all these parts of these operations one by one, stage by stage, and not only can the surgeon use it to do it, but also those of you who are interested can look and see how it is done, and you can see what the results are. The results are generally excellent. There's a variability based on pre-existing conditions, patient status, and the extent of the dissection before the operation. The postoperative complications are neurologic events, and postoperative bleeding, and nerve injury, and delayed descending aortic dissection. In other words, if you perform an operation in the ascending aorta, then that patient's at risk for dissecting the rest of the aorta, and one has to be mindful of that and then act on it if it does occur. The last part of this presentation has to do with anomalous aortic origin of the coronary arteries. Coronary arteries can come off the pulmonary artery. Coronary arteries can come off of different areas of the ascending aorta. And today I'm going to talk about the various origins of the coronary arteries from the ascending aorta, not the pulmonary artery. And so the surgical, basically there are two types. One is the left coronary artery coming from the right coronary cusp, and the other one is the right coronary artery coming from the left coronary cusp. This exists in nature, and it gives us headache, or the patient headaches, let's put it that way. And it's a threat to that person's life. The surgical indications, usually from left from right, are just require surgery on contact. And right from left, most centers really require findings before the operation, although this has not been totally agreed upon. The operations can be complicated. Coronary bypass is rarely indicated, rarely, emphasis on rarely, and unroofing is a preferred approach. So this is how it looks in the operating room. This is a right coronary artery from the left coronary cusp, right coronary cusp, non-coronary cusp. And notice that this is going intramurally within the aortic wall and comes out here. Ordinarily, most of the time, the orifice is also small. It's called a slit-like orifice, and this can yield angina and, in some cases, sudden death. The operation is to unroof basically what's going on here. The channel from the left coronary cusp to the right coronary cusp, and then put tacking sutures to prevent a dissection. This is sometimes the course of the artery is below the commissure of the aortic valve, and this requires special attention. You can't go through this, otherwise you'll make the aortic valve incompetent. And then one can make two holes, one there and one here, and then make the orifice into the right coronary artery whole again. This is a left coronary artery coming from the right coronary cusp, left coronary cusp. This is what it looks like in the operating room. And one can perform an unroofing, as you can notice here, and then do the tacking sutures to prevent dissection. And notice that the orifice, the left coronary artery, is made whole. This, just like the right coronary artery, the course of the coronary is below the commissure, and this requires two holes to be made. So in order to get to the orifice of the left coronary artery coming from the left coronary cusp, this is what it looks like when the operation is finished. This is a very rare condition. Up until recently, was thought not to have any way to operate on this patient. This is a left coronary artery coming from the right coronary cusp, and then the LAD dives deep into the muscle here, and this muscle serves as a vice around the coronary artery, which can compress the coronary artery and cause symptoms. In some cases, this can be more than symptoms. It can be a myocardial infarction. The idea is how to deal with it, and one can transect the pulmonary artery as shown here, and then unroof this and the myocardium all the way over to where it comes out into the interventricular septum. And then, of course, it's a small matter to put the pulmonary artery back together. Now the coronary artery is completely unroofed. There are misadventures with this operation, and it's important to know what the misadventures are so you can deal with it at the time of the operation. This shows the coronary unroofing procedure. It's being done right here, and lo and behold, this operator made the incision just a little bit too long and got outside of the aorta. No problem. We'll put the sutures here. Sutures are placed there. No worries. Close the aorta. And then there was a little bit of bleeding, maybe. So another suture is placed here. The cross clamp comes off, and there's a lot of bleeding right here. So more sutures, maybe. More sutures means a bigger hole. So the best thing to do here is to eat your ego and go back on, recross clamp the aorta here, and then cut out this area that has multiple holes in it. And notice that here that's being cut out. And then take a piece of a pulmonary artery, which is tailor-made for this situation, and use it as a patch in the coronary artery. Use it as a patch on the coronary artery, and this takes care of the problem. Sometimes one looks in the aorta and has a hard time finding the coronary artery. In fact, sometimes the coronary artery can be right behind here, and unless you know where to look, you won't find it. Sometimes this is below the coronary, the commissure here, and in these cases, it's best to make the incision down from the aorta and out onto the pulmonary coronary artery, and use a patch, of course, from the pulmonary artery here, and use this patch to do a coronary arterioplasty with this piece of the pulmonary wall, and this is what it looks like when it's finished. And here's what it looks like when it's finished. Sometimes the coronary button has to be moved, and one can mobilize the coronary artery here, showing the right coronary artery from the left coronary cusp, and it's going to go in this position. And this is sutured with a piece of pulmonary artery wall, and this looks great. And the patient comes off bypass, and there's a EKG changes, and say, what's going on here? And in fact, what's going on is that this coronary is kinked because it goes into the muscle here, and this muscle was not unroofed. One unroofs it with some bovine dissection, and now everything is fine. EKG problems go away. So the results in general are excellent. The complications require expeditious resolution and go back and fix it. And postoperative cardiac catheterization may be necessary, and postoperative imaging is generally performed, although not in all centers. So in summary to this discussion, the adult congenital heart surgery part of the world is increasing, owing to the fact that more children are surviving into adulthood. A snapshot of operations have been presented, as we noted right here. And thank you very much for your attention, and look forward to any questions. Yes.